Hello everyone. Let me first introduce myself. I am Dr. Hamouda Ouanassa. I am an associate professor of parasitology and mycology at the Department of Medicine at the University of Batna, Algeria. Today, I'm going to present to you my work entitled Candiduria in Renal Transplant Recipients. Introduction. Solid organ transplantation has been established as a treatment for patients with end-stage kidney disease. The first successful kidney transplant between identical twins in Hospital Peter Brigham in Boston on December 23, 1954. In fact, it is considered a regular practice of nephrology and the treatment of choice, as it improves not only the quality of life of patients but also their quantity of life. The immunosuppressive therapy has reduced the possibility of transplant rejection but promote the occurrence of certain infectious complications, in particular viral and bacterial, but also to opportunistic microorganisms of the fungal type and parasitic. These infectious complications could negatively affect the clinical prognosis. They remain a major cause of morbidity and mortality in this group of patients, despite improved surgical techniques, antimicrobial prophylaxis, new immunosuppressive therapy regimes, and hygiene measures. Candida urinary tract infections are not as frequent compared to bacterial or viral infections in renal transplant recipients with a percentage of 2%. The use of the Candida gens are commensals of the digestive, vaginal, and skin mucous membranes. It becomes opportunistic by taking advantage of a state of weakness, temporary or prolonged vulnerability of the host to implant themselves and express its pathogenic power. Candidiasis are varied from superficial to systemic forms. The distinction between colonization and infections is often difficult to establish. The aim of this study is to establish the epidemiological profile of Candiduria in renal transplant patients hospitalized in the nephrology service at the University Hospital Center of Batna, Algeria, to know the Candida species the most incriminated and to search for the various risk factors involved. Patients and methods. This is a prospective study spread over a 6 month period from January 1st, 2017 to June 31st, 2017, involving 35 renal transplants. The data were collected prospectively in real time using a standardized information sheet. As with any biological examination, the quality of the mycological analysis requires mastery of the pre-analytical phase, which includes taking the sample and sending it to the laboratory. The urine collection technique involved several steps: careful hand washing with a mild antiseptic, disinfection of the vulva in women and the urethral meatus in men with an antiseptic, then collect urine in the middle of the stream in a sterile 10 cc swab. Immediate transport to the Parasitology-Mycology laboratory. In the laboratory, the urine is centrifuged at 3000 per 5 minutes. The urine was then homogenized using a vortex type checker. The contents are ready for direct examination and culture performed on solid saborochloramphenical inclined media in 10 cc tubes. The cultures were then incubated in the oven at 37 degrees Celsius for 24 to 48 hours. The identification of the different Candida species was carried out by using the API Candida gallery of bioMérieux based on the assimilation of sugars and enzymatic tests. A yeast count was performed using a molasses cell to determine the concentration of yeast in each urine sample. General distribution of patients, epidemiological data. The study population consisted of 35 patients who had undergone a renal transplant and hospitalized in the nephrology department at Batna Algeria University Hospital, including 8 patients, 23%, presented with Candiduria. Distribution of patients by sex and age group. Our patients with Candiduria, 8 patients were women. The age group between 40 to 59 was the most representative. 4 out of 8 patients, 50%. The reasons for hospitalization of transplant patients with Candiduria are different. Transplant rejection was the most frequent reason for hospitalization, followed by sepsis. The main risk factors found in our patients were the immunosuppressive and corticosteroid treatment found in our patients to avoid graft rejection, followed by broad spectrum and prolonged antibiotic therapy, which is present in 75% of patients. Total distribution of isolated species. After the identification of the Candida species in the different urine cultures, we noticed the predominance of the species Candida albicans, 62%. The association of Candiduria with bacterial infection was found in 5 of 8 patients. Different germs have been isolated: Escherichia coli, Pseudomonas aeruginosa, Staphylococcus aureus, Klebsiella. 3 patients had isolated Candiduria. The quantification of the yeast for the 8 transplanted patients demonstrated a significant number of yeast in the majority of cases, 75%, with a number greater than 100,000 CFU per milliliter, as well as a significant increase depending on the length of hospitalization. Global evolution of patients with Candiduria. 3 cases of candidemia were diagnosed in patients with high Candiduria. The death rate in our study was 37.5%. They all had candidemia. Discussion. In our study, the prevalence of Candiduria was 22.85%. In comparison with a study done at the University of Wisconsin, the rate of Candiduria was 11% in renal transplant recipients. In the present study, Candiduria affected only women, which is not the case in other studies which have shown that Candiduria also affects men. The female predominance can be explained by the fact that the urinary tracts are shorter. Germs can enter and spread more easily. Thus, Candida saprophytic from the vagina, which facilitates infection by contiguity. The age of renal transplant patients with Candiduria was in the age of range of 40 to 60 years. Studies have not shown a significant relationship between age and the occurrence of Candiduria in hospitalized renal transplant patients. All transplant patients undergo heavy immunosuppressive therapy to prevent all transplant rejection, which leads to immune system failure and is considered a first-degree risk factor. Broad-spectrum antibiotic therapy is a risk factor found in 75% of our patients. Candiduria can be associated with a care equipment, urinary catheter, central venous catheter, mechanical ventilation, etc. In our study, the majority of patients, 75%, had urinary symptoms and 25% were asymptomatic. 3 patients had confirmed candidemia with positive blood cultures. This rate is quite significant when compared with other studies. Candida albicans were the most frequently isolated species, which is consistent with the majority of studies. The emergence of non-albicans species in some studies, such as Candida glabrata, in connection with the increasing use of fluconazole in the curative and preventive treatment of candidiasis, after carrying out a numbering of the yeasts, it was observed that the number of yeasts increases according to the length of hospitalization. In the present study, cultures with above 100,000 CFU per milliliter are found in 75% of cases. This study demonstrated the role of Candiduria as a potential risk factor for systemic infection candidemia. 3 cases of candidemia were diagnosed in patients with high candiduria. The death rate in our study was 37.5%. They all had candidemia. Conclusion. In renal transplant recipients, Candiduria is associated with morbidity and high mortality. It's essential to take into account post-transplantation mycological monitoring in these patients. Through this work, we have tried to determine the epidemiological profile, incidence of Candiduria, analysis of risk factors, as well as mycological data. The early diagnosis of Candiduria as well as the identification of the species involved allows for better as well adapted therapeutic management. Overall, and despite the limitations imposed by the relatively small number of patients, the study provided a general description of Candiduria and its risk factors in renal transplant recipients. Finally, it's necessary to strengthen hospital hygiene measures and to respect rigorous aseptic measures during catheterization and the ablation of indwelling bladder catheters. It's also necessary to continuously sensitize the population of the danger of the uncontrolled use of antibiotics. Finally, thank you for your kind attention.